Here's a screencast for EMS 150, Lesson D. We're going to talk about cardiogenic shock, definition, assessment, emergency interventions, all things about cardiogenic shock. Cardiogenic shock is a failure of the pump, failure of the heart to pump adequately. Now, why would that be? Well, it could be that it's not pumping fast enough. Or it could be that it's pumping so fast that it can't physically fill. There's not enough fill time between contractions. That's a pretty key point, key concept for you to understand. Remember that you would think that cardiac output would go up because cardiac output is heart rate times stroke volume. So if the heart rate went up, wouldn't it make sense that cardiac output goes up? And that's true up to a point. But the heart fills using gravity to start with. The valves open from the atria to the ventricles. The blood dumps into the ventricles. And then the atria contract and do a little extra squeeze. But it just takes time. It's a very short amount of time measured in milliseconds, but it just takes time. And there is a point where that rate becomes too fast for good filling to occur. In the otherwise healthy heart, that rate is in the 150 to 160 range. And in a not healthy heart, it may even be slower than that. It may be somebody in the 120s, 130s, is having problems due to the tachycardia, due to the rapid rate because of the decreased filling time. Another reason we could have cardiogenic shock is that the stroke volume is just too low. The heart itself is not squeezing hard enough. The ventricular muscles are damaged or hypoxic, and they just aren't able to pump. Or stroke volume can be down because of too little preload. Preload is too low. So another key concept there. We talked about rate. It could be that it's just too slow, not pumping often enough. That makes sense, I think. Could be that it's too fast, that there's not enough filling time. Hopefully that makes sense. And the stroke volume could be low either because it's not squeezing hard enough or it's squeezing just fine, but there's not enough blood coming to the heart. Reduced preload will reduce stroke volume. Then the other concept is the afterload could be too high. It could be that the heart is pumping at the right rate, not too slow, not too fast, and it's pumping hard enough, it's squeezing hard enough, and it's got enough blood coming to it to actually be able to put out enough blood, but the pressure it's pushing against, the afterload, the systemic vascular resistance, the amount of arteriolar vasoconstriction is too high. So it could be several things. Cardiogenic shock, as you may already have guessed, is not as simple to understand as hypovolemic shock. There are multiple factors involved. So again, why a rate problem and what kind of things would cause a rate problem? Well, as you get further into the EKG course, you'll learn about conduction system defects, such as an AV block. What this means is that the AV node is not allowing enough impulses to come from the atria and to the ventricles. So because of some sort of a malfunction in the AV node, there are not enough impulses getting to the ventricles, creating a bradycardia. What could go wrong with the AV node? Well, it could be a disease. It could be just old age. It could be there's an electrolyte problem there. It could be that the AV node is ischemic, doesn't have enough oxygen. It could be something about medications. It could be street drugs, some sort of tox problem. There are lots of things that can cause conduction system defects. And so if those are occurring and you do have a significant AV block that's not allowing frequent enough impulses to make it to the ventricles, you get a bradycardia. On the flip side, it could be something very rapid and chaotic going on to where now we have an extreme tachycardia. Maybe there is a loop circuit, a short circuit or loop circuit that's developed in or around the AV node. Or maybe the ventricles are just irritable and they've started into a VTAC. So it could be very slow or very fast, and those are usually cardiac rhythm problems. And so what you'll learn is that when you have a patient with low blood pressure, we're going to fix the rate first. If the rate is the problem, we fix the rate first. How do you fix a slow rhythm? Well, you have to deal with what is causing that cardiac rhythm disturbance. How do you fix a fast rhythm? You deal with what's causing that cardiac rhythm disturbance. Sometimes our parasympathetic nervous system is just overly active. There's too much vagal tone, too much vagal response. And so the brakes are on too hard. And maybe that is what's causing bradycardia. So it's either a rhythm problem, and we have medications and electricity, therapies for that. Hopefully they're fixes, but therapies for that. Or it could be that it's a parasympathetic nervous system overactivity. There's too much parasympathetic and not enough sympathetic. So there's a need for you to understand what's going on in order for you to decide what tool to use, as opposed to just the old EMT kind of level thinking of, I see something and I treat, and I don't really have to understand what's going on. You need to kind of understand what's going on here. So cardiogenic shock can be a rate problem. It can also be a stroke volume problem. It could be that the guy had a massive heart attack, so a whole bunch of his left ventricle is not pumping. It could be that he had several other myocardial infarctions, heart attacks, to where now he has a critical mass of that left ventricle is just not pumping effectively. Maybe the valves between the atrium and the ventricles aren't working right. Maybe the valves outbound from the heart, either on the pulmonary side or the aortic valve, maybe they're not working right. Maybe the patient is septic. Maybe he's had some sort of toxicology problem or electrolyte problem. Maybe it's a potassium level problem, or maybe he's simply septic. There are other things that will depress the pumping activity of the ventricle. So how do you find out if your patient really is in cardiogenic shock? You can tell that they're shocky because they have signs of shock with or without a decreased blood pressure. But how do we nail it down to where it's cardiogenic as the key, and we can go to the cardiogenic shock tool bag and start pulling those things out, as opposed to simply start an IV and give him fluid? If give a fluid bolus is your first and only therapy, then you're going to miss the ability to treat a lot of patients in shock that's not hypovolemic. Not saying that a fluid bolus isn't a tool to use in cardiogenic shock sometimes, but I don't think it's your first tool. And so if you're one of those cookbook medics that just says, oh, low blood pressure, it looks like shock, better start an IV, you're not going to treat your patients as well as you should, as well as they expect. And don't worry, we won't let you out of the course if you're that kind of medic anyway. So heart rate's the first thing to think about. Is it too slow or too fast? In general, the rule is going to be in an otherwise healthy heart, rates of less than 50 or more than 150 are a big freaking deal, and we ought to fix those first. Look for JVD. Look for peripheral edema. See if there are signs of right heart failure. Listen to lung sounds. For crackles, see if there's signs of left heart failure. And the BP does matter. The BP matters as well as other types of BP, the MAP, the mean arterial pressure, and the pulse pressure, the difference between systolic and diastolic. All of these things go into your assessment of the shock patient to determine what type of shock he's in, so you can determine what type of tools to use. Again, quick review, cardiac output's the amount of blood pumped in 1 minute. That's a definition, and so you should really know that. That's a key concept, and really you're just completely struggling and floundering if you can't come up with cardiac output. Oh yeah, that's the heart rate times the stroke volume. It's the number of times the heart beats multiplied by the amount that's pumped with each contraction. Why do we care? Well, if the problem is cardiac output, is that a rate problem or a stroke volume problem? Or is it both? But we're going to attack the rate first in almost every case. And remember that blood pressure is determined by three things: the two components of cardiac output, heart rate and stroke volume, and that third critical component that you understand, the SVR, the systemic vascular resistance, the afterload, the amount of vasoconstriction in place. Peripheral blood vessels should stay a little bit constricted, but not completely. They can dilate some, they can constrict some. They're in a medium sort of constriction phase in there. And so when that constriction is too much, you have too much afterload, and no matter how good your heart's doing, it's still struggling to push against that resistance. And then again, when we talk about distributive shock, that's the case where your SVR is incredibly low. You have low afterload, and even with normal cardiac function, you've got a crappy blood pressure. So blood pressure is a key concept. Blood pressure is made up of heart rate and stroke volume, which is together called cardiac output, and SVR. SVR, again, I said amount of arterial and arteriolar constriction. It's on the arterial side. How much constriction is there? How much resistance is there to blood flow coming from the heart? We want there to be some. We don't want there to be too much. We want the container size to be appropriate. We don't want an inappropriately large container size, as would be the case in the distributive shocks, the abnormally low SVR. Distributive shock types are anaphylaxis, sepsis, neurogenic shock. And those lessons are coming. But right now we're talking about cardiogenic shock. So what do you do about cardiogenic shock? Well, you have to figure out what the problem is. You don't just start replacing parts. You have to diagnose the problem. Don't be one of those mechanics that just says, well, let's change this and send the car back out. There's no bringbacks in EMS. You need to get it right. So you need to have an assessment of what's the problem. If the rate's too slow, well, let's speed it up. If the rate's too fast, let's slow it down. We're going to work on rate first. Then we can work on stroke volume. If stroke volume is a problem, then let's increase their preload or do something medication-wise to them, a positive inotrope that increases their stroke volume. And then if afterload's the problem, adjust that if you can. Reduction of afterload in the field is not all that easy. The tools that we have are somewhat hard to use. And then adjust preload. Adjusting preload's easy, right? Lay them down, give them IV fluids, adjust preload pretty quickly. All those key concepts. This is one of the more important lessons in this course based on just the number of key concepts that we talk about. So how do we increase a slow rate? Well, we've got electricity via transcutaneous pacing, and you'll practice that in the lab. And then we have medications. We can take off the brakes with a parasympathetic antagonist, or we can push on the gas with a sympathetic agonist. Terms that are good for you to know so that you can communicate with other medical professionals, you can read journals, you can read textbooks. This is the language of pharmacological intervention, and you should know these terms. So if the rate's too slow, we can try taking off the brakes, we can try pushing on the gas, but that takes a little bit to get that therapy going, and it may be that we need to just quickly place the pacing pads and start pacing. How to pace is something for the lab. When to pace, we talk about here. So it could be that your patient's in cardiogenic shock because his rate's too slow. We may need to use electricity, we need to take off the brakes, we need to push on the gas. It could be that he's in cardiogenic shock because his rate's too fast. There's just not enough filling time. We have electricity for that also. It's called synchronized cardioversion. Unsynchronized cardioversion is really also called defibrillation. So we have the ability to shock the heart, stop all the electrical activity, and hope that normal processes take over from there. It's just basically calling an all stop, and then, all right, now let's get back and let's work on this like it's always supposed to have been. And sometimes that will work. We also have some meds to do rate control for tachycardia, extreme tachycardia. I'm not talking about a heart rate of 110, I'm talking about a heart rate of 180. So we have medications. If the problem is in the AV node and there's chaotic activity going on in the AV node, then we just Control-Alt-Delete the AV node. We just reboot the AV node with adenosine. It could be the patient's taken too many calcium channel blockers and their heart rate is too very, very, very low. Or it could be that we could use calcium channel blockers in these extreme tachycardias to slow them down. CCBs are negative chronotropes, as are beta blockers. So a sympathetic antagonist, the beta blocker, would keep beta 1 effects from occurring, would keep the heart from increasing, keep the heart from pumping harder. So we may need to use some beta blockers. Those are in your pharmacology list. Or it could be that this is a rhythm problem that is just a chaotic rhythm or an abnormal tachycardia, and we may need to use an antidysrhythmic such as amiodarone. In the past, and probably coming back, we've had lidocaine and procainamide. Right now, it appears that amiodarone is the go-to, and we'll talk a lot about amio in your course, about how it's the crescent wrench of medications, to where it's really supposed to do one thing, but you can pry with it and hammer with it and do some other stuff with it. And remember, the deal with amio is that once you give it, your patient wears it for 6 weeks. Its half-life is quite long. whereas adenosine, over and done with in seconds. Amio is not over and done with for many, many, many days. So anyway, there's a lot to learn here, and we're talking about cardiogenic shock, where you have, as in the previous slide, too slow a rate and some tools and techniques to increase the rate. In this case, too fast of a rate, and you have some tools and techniques to decrease the rate. But then what else? It could also be stroke volume. Remember, cardiogenic shock could be from cardiac output, either rate or volume, as well as SVR. So SVR is coming, but now we're going to talk about stroke volume. If you need to increase stroke volume, you'd want a positive inotrope, something like a dobutamine or a dopamine or an epinephrine. Another way to increase stroke volume without trying to make the heart beat harder and therefore need more oxygen is simply to make sure the heart's getting plenty of blood. So normalize preload. If preload's too low, then increase it. How do you get someone's preload up? Lay them down or give them fluids, or both. It could be that you want to decrease their preload. And how do you decrease preload? Well, sit them up, give them a vasodilator. Nitro comes to mind. So these are key concepts that you should know. How do you increase stroke volume? Well, you can do it with inotropes or by adjusting preload. How do you even adjust stroke volume? Let's just say it that way. How do you adjust stroke volume? Well, if I want to increase it, I give a positive inotrope. If I want to decrease it, I give a negative inotrope. If I want to increase stroke volume, I increase preload. If I want to decrease stroke volume, I decrease preload. So be sure you don't think of it as one or the other. If you want to mess with stroke volume, you can do it through inotropy or you can do it through preload. Preload, again, the amount of blood coming back to the heart. When you're sitting or standing versus laying back, you have different amount of blood coming back to your heart just because of venous return. There are meds that can reduce preload, like nitro. There's ways to increase preload by increasing volume. Then I want to talk about Starling's law here for just a second. The Frank-Starling mechanism. It's two different guys. One's last name is Frank, the other's last name is Starling. They have a law of the heart, or they have a mechanism or whatever. When you hear Starlings, this is what it's talking about in EMS. And the deal here is, think of a rubber band. If you want to pop someone harder with a rubber band, you need to stretch it further. If you want that ventricle to pump harder, you need to stretch it more. How do you stretch it? Preload. Preload stretches that muscle and improves its pumping up to a point. So you can see on the simple graph that as we increase stroke volume, on the curve there you get to a maximum capacity. Past that, increased preload doesn't do you any good. The problem is that these people don't have a meter or a graph or a LCD screen on the outside of them. You can't really look at them and see what their preload's doing, what their SVR's doing. We can look at their rate, but if you think of a person as having dials to turn for rate and stroke volume and SVR, that's great, but we don't have a meter to go with those dials. We don't know what those levels are. In the ICU, they have more data to make these same decisions than we do in the field. So again, a challenge in field medicine, which makes it fun, I think, is that you have to make decisions with incomplete information. You have to make judgments with incomplete information. How do you make those judgments? At the patient's side, when it counts, you need to be thoroughly versed in this material so that you can recall it and understand it. Simple memory or the use of a badge buddy memory aid is one thing, but this stuff doesn't go on a badge buddy. This stuff comes from your brain. You've learned this and you understand this. So we talked about rate, we talked about stroke volume, and now we're going to talk about SVR. There are some meds that are positive alpha and will increase SVR, increase the afterload. Norepinephrine is an example. Dopamine at levels of greater than 10 mics per kilo per minute is an example. Epinephrine in increasing doses gives you positive alpha, vasoconstriction. Then if you want to reduce afterload, you would need a negative alpha or some sort of arterial or vasodilator, high-dose nitroglycerin will do that. A nitroglycerin infusion will do that. So how do you increase afterload? Positive alpha. How do you decrease afterload? Negative alpha, which usually comes in some sort of vasodilator sort of thing. So Lab D, we will do some work on EKG acquisition, and we will hammer home the point about lead placement matters. Misplaced leads equals to misplaced analysis of that rhythm. So we want to make sure you're good at that, and you're not one of those folks that just looks at the chest and starts throwing electrodes down, that you actually find the right spot. You've got to find where V1 goes. Everything keys off of V1. If you're off on V1, all the rest of your leads are off. This does matter, and we should be doing it right. And you may or may not have been taught correctly on this, but you're going to be good at it by the end of this lab. Then we're going to let you get some time on just the mechanics of cardioversion. Not when you should do it, but just how do you do it. Well, you probably already know how to defibrillate, so that's unsynchronized cardioversion. We want to work on synchronized cardioversion as well. And so really, again, it's not a thorough understanding in this lab in the early part of your program, one of the first courses and first block. We're not going to really understand when, but we are going to get some reps on how to do it and probably why. Then same thing on transcutaneous pacing. Pacing someone is not difficult in terms of doing it. Deciding if it's the right thing to do is a little more complex. Deciding if it's working and what to do next is a little more complex. But the actual mechanics of doing it, you simply set the rate and you turn up the output current until you get capture. So finding capture is the key concept. And once you figure that out, you're fine. And we'll teach you to do it with your eyes. We'll teach you to do it with your ears. Find capture. Then you want to check for mechanical capture, because nobody said that just because your pacer is making a rhythm that's at the right rate, that's actually turning into mechanical pulse-making activity. So there's some key stuff for you to learn in Lab D, but the lab piece of this is really going over things and machines and such. Please go back through and work the assignment and look at the resources and absorb all this other conceptual stuff that we talked about just prior to this. So we'll see you in Lab D.